Good evening, everyone, and welcome to this Thursday Facebook Live discussion and Q&A brought to you by Vetorical Teleneurology. It's a beautiful day here in the south of England, and I'm delighted to see that my colleague Simon is wearing his old man cardigan. He told me that it's actually quite cold in Georgia. So for once, we have a better weather than him. I hope you are all managing okay. I know it's been a difficult, time. I know also you are doing your best to provide all this care, to our animal, and that this Facebook discussion that we've started running provide you with some good tip to help you, with your clinical practice. That's the main aim, and also to provide you a little bit of entertainment, especially considering that what is on TV these days is quite poor with the lack of new program. I know some of you have been doing also a fantastic job providing equipment to hospital, which is amazing when you see the veterinary profession helping the human field, which is an amazing thing that a lot of you are doing this day. We had an amazing response to our Facebook Live. This is the third one. There is approximately 300 of you every Thursday joining us live. We had more than 7,000 to 8,000 watching after that. So thanks a lot again for all your support. The format will, if you're new to this Facebook Live, is very simple. Every week, Simon and I, we have a guest, and we ask a number of questions to our guest. We have a specific area of expertise. And then we open the floor to question, and you are very welcome during the presentation to type in the comment box some question, which we'll then put to our guest. This leaves me to introduce our fantastic guest tonight. She is Spanish. I call her the queen of neuroimaging, Ines Carrera. She is also the latest recruit to our new company, Vetorical Teleneurology. When we created this concept of Vetorical Teleneurology, our aim was, before all, to create a team of the best people in the field of neurology and imaging to provide you with the best report, and the report that will be practical and relevant to the clinic. I had to invite Simon because he was obviously an old friend of mine. But that apart, we wanted to have really the best of the two worlds, and to show that the two worlds can work together to provide you this quality, service. Ines is Spanish, as I say. She's done a residency in Glasgow. She traveled all over the world to enhance all her knowledge about imaging, but she has a particular interest at neuroimaging. And to me, she's one of the few people in the world that really stand out in terms of being there in knowledge of neuroimaging. She's done a PhD on MRI spectroscopy. She has done extensive research. She really, knows her stuff with regard to neuroimaging. And we couldn't have a better person tonight to talk to you about neuroimaging. So that leaves me to leave the spot to Simon to ask Ines a number of questions that we selected, for you. And then feel free during this presentation to put, your question in the comment box, and I will, at the end, take over to put this question to Ines. Simon, over to you.
All right, thank you very much. And welcome, Ines. Thank you for joining us. Firstly, may I say to Laurent, thank you. You've left us with 30 seconds of this after your introduction. And you're not fooling anyone by having a spotlight on your face, pretending it's the sun in England. Trying to mock me for wearing my granddad's cardigan is a low blow. When you're isolated, you get to wear clothes you haven't worn for a long time. Just try them out, a new look, So these are trying times for everybody. And as Laurent said, We hope to make them a little bit better for everyone watching. And Ines, as Laurent has introduced, is our guest today, and we're very honored to have her here, help us answer some questions. And the focus today is using MRI imaging to help us differentiate and understand a little bit more two very common conditions that we see in the dog. So firing away with question number one, Ines, are you ready?
Yes.
That is. What do you understand and how can you explain to our viewers today the difference between the acute nucleus pulposus extrusion, the non-compressive version, and fibrocartilaginous emboli?
Okay, so these are two conditions that are quite similar clinically because they start as a peracute onset of neurological dysfunction, but they have quite different, and they are normally not progressive over 24 to 48 hours. So clinically, they may seem quite similar, as I say, but they are completely different processes. So acute non-compressive disc extrusion is an extrusion of a hydrated disc. And this is due to a sudden increase of discal pressure because of vigorous exercise or a trauma. And this explosion of the disc causes a contusion of the spinal cord, which causes the myelopathy and the consequent clinical signs. And then the disc material dissipates within the epidural space and causes non to minimal spinal cord compression. And on the other hand, FCE is a vascular disease. This is caused by an emboli that is fibrocartilage material that is quite identical to nucleus pulposus. And what it causes, being a vascular disease, is ischemia of the spinal cord. And there are 4 different hypotheses of how this disc material gets to the spinal cord vessels, which can be either arteries or veins. And actually nobody knows. It can be just direct penetration, or some people think that is a cause of chronic inflammation and neovascularization, or remands of vessels that are formed since the dog is a puppy. So, well, these are hypotheses, but nobody knows how exactly disc material gets there. But this is what is normally found in histopathology. If we can see the next slide, in histopathology, these 2 diseases are also very different. And what is found in acute non-compressive disc extrusion is gelatinous material within the epidural space and some hemorrhage as well sometimes. And the contusion that is caused by the explosive disc material causes a malacia of both the white and gray matter. And surrounding this area of malacia, there is degenerated white matter with diffuse microgliosis, which means that all this lesion is going to be very ill-defined in the spinal cord. And so this is important to understand when we are looking at imaging. And in FCE, what is found in histopathology is no extradural material at all. And they find this fibrocartilage material that is disc nucleus pulposus within spinal vessels. And because it's the spinal vessels are functional arteries, veins, causing this ischemia, is normally affecting more the gray matter than the white matter because they require more oxygen. So it's always, both are affected, but normally it's gray matter way much more affected than gray matter. And because it's a territorial area, the lesions are very well defined. It's very rare to find hemorrhage within the spinal cord. Like In infarcts in the brain, it can be some hemorrhagic transformation because of rupture of vessels. This is less common in the spine, while on the acute non-compressive disc extrusion, it's quite common actually to see hemorrhage, intramedullary hemorrhage, apart from the extradural hemorrhage that I said before.
Great. Well, that is a great introduction for us. Gets us going. So we've got two acute conditions of the spinal cord. And from our point of view, it can be difficult to clinically distinguish. They can sometimes look pretty similar. One you've talked about as an extradural problem, one is a parenchymal problem. Both may create a situation of an acute neurologic dysfunction where they're not really painful on examination. Can you use MRI to distinguish between these conditions, and how reliable is this?
Yeah, actually, yes, we need to look carefully. And it's actually the diagnosis that is normally presumptive is based on MRI, because CT and radiographs of CT and CT myelography are going to be quite unspecific. So we do need MRI to confirm the clinical suspicion. And to distinguish between them is if we keep in mind what the pathophysiology of each disease, acute non-compressive disc extrusion and FCE, we do see the differences in MRI. And starting with the acute non-compressive disc extrusion, what we find in MRI is extradural material, which is a very mild amount, minimal, not causing spinal cord compression, but we are going to see an irregularity in the epidural space, and perhaps some obliteration of the subarachnoid space as well. We always find an ill-defined intramedullary lesion that is always at the level of the disc space. It's always centered at the level of the disc space. And it makes sense because it's a concussion and an explosion of the disc. And then it may extend cranially or caudally from that level, but normally it's rather focal and doesn't extend, as a general rule, more than one vertebral body. The signal intensity is normally hyperintensity 2. It's variable in T1 depending if the lesion has hemorrhage or not, or if it's hemorrhagic. And if it's hemorrhagic, we pick it up very nicely on gradient echo sequences in T2 star, where we are going to find areas of signal void. And the lesions, the intramedullary lesions, they are going to be ill-defined, as I said, and they are going to affect gray and white matter in quite similar way, or degree. And if we use contrast, we may see epidural and meningeal enhancement. So now I will show you all this in images. So in the first image, we have a T2 sagittal of an adult dog with peracute neurological size of paraplegia. And what we see here is the, first of all, if we look at the intervertebral disc, it's a bit difficult or challenging to relay on the signal intensity and the shape of the disc when there are many others that are degenerated. So if we compare the intervertebral disc between T13 and L1, if we compare it with L1, L2, that one is degenerated, so there is no comparison. If we compare that with the cranial one, we may see that the one at T13L1 is a bit smaller. And if we look carefully, we may see a cleft on the dorsal aspect. But well, again, it's a bit difficult just to judge very much the intervertebral disc. So the red arrow is pointing an intramedullary lesion that, as you see, is centered in the intervertebral disc space. And the yellow arrows are pointing that the subarachnoid space dorsally is a bit obliterated, indicating that there is a spinal cord swelling. If we now look at the transverse views, so the green line now on the sagittal view is where the transverse view are the ones that we are showing. So we have a T2 transverse and a 3D high resolution. This is a steady state gradient echo. It's based in T2 and it's high resolution because it's 1 millimeter slides, very thin slices without gaps between them. So we are able to assess the whole anatomy very nicely. So in this one, it's very useful to have these sequences because we can assess the whole epidural space very nicely. And what we are seeing in these images, the red arrows are pointing the epidural space that is very irregular. It's slightly hypointense, and we see that better on the high resolution. And the subarachnoid space is also obliterated, but you can appreciate that there is no significant spinal cord compression. There is no an extradural lesion that requires surgery. On the next slide is just slightly cranial to that, just a little tiny bit, and we appreciate this, the same, even better on the 3D high resolution, that we see that the epidural space is slightly irregular and it's got a hypointense material that is not compressing the spinal cord much. And on the next slide, that is slightly cranial to that, on the T2 transverse, the yellow arrows indicate the hyperintense intramedullary lesion. And notice that both the gray and white matter, they are affected, and the signal intensity that we see between them is very similar. So we don't differentiate gray and white matter because both have similar signal intensity. And on the 3D high resolution, we are still seeing how the epidural space is irregular and hypointense when compared to the other side. And on the T2 star, the gradient echo, the orange arrow points a very small region of signal void that indicates a small focus of hemorrhage. So this is the typical appearance of a non-acute, non-compressive disc extrusion. And I have another example in the next slide that we start again with a sagittal. And again, the red arrow points the intervertebral disc that, again, the one caudal to it is degenerated and the one cranial to it is not degenerated. So it's very difficult to compare between them and see if this one is normal or not. But as a general rule, again, because this is, as I said at the very beginning, the extrusion, the extruded material normally is hydrated. It's not degenerated like in the typical type 1 Hassen type. So in this one, we also see the yellow arrow indicates the intramedullary lesion that is just at the level of the disc space. And if we see in the next slide the transverses, we can see that there is a really mild extradural lesion ventrally, pointed by the red arrow, but it's not compressing the spinal cord. Again, we don't need surgery in this case. And we have a quite linear intramedullary lesion that is hyperintense in T2 and is hypointense with signal void in T2 star. This can be the tract of the contusion because it could be quite sharp. And another possibility is that part of the disc material is actually inside the spinal cord. That is, this could also happen in this kind of disc extrusions. And This next slide is to show that normally, in these cases, we don't use contrast. If we use that, it's quite beneficial because we can appreciate that the epidural space and the meninges are quite inflamed. This helps us to differentiate maybe from other diseases, because if we have, for example, meningitis only, we shouldn't expect anything within the epidural space, any enhancement, particular enhancement within the epidural space. I took these images from the paper that we see here, and they use FAT-SAT T1 post contrast. I think this is extremely important because the epidural space is hyperintense in T1 and in T2. But if we are using a T1 post contrast, if we are assessing the epidural space and the epidural space is hyperintense, you're not going to see any contrast enhancement. So it's very important if we want to look for this, so we take this into account, to always use FAT-SAT T1. And we also need to take into account that these kind of sequences, FAT-SAT T1, we can only use them in magnets that are above 1 Tesla. They don't work in low field MRI. So if we continue with MRI findings in FCE, they are different than in what we have seen now in acute non-compressive disc extrusion, because we are not going to find an extradural lesion. And if we find an extradural lesion, maybe it's a chronic protrusion, but it's not going to be an ill-defined lesion within the epidural space as we just have seen now. The intramedullary lesions are also quite different because normally they are sharply demarcated and they may affect the gray and white matter, but the gray matter is more affected than the white matter. And this is because it's a vascular disease. Gray matter has more demands in oxygen, and this is what we are going to see on the MRI, more hyperintensity in the gray matter compared with the white matter. It can be quite focal, but also it can be normally, or most of the cases is quite extensive, and it can affect more 1 or 2 or 3 lengths of a vertebral body, but also it can be normal, and it can be normal overall if we are scanning the dogs too early, maybe within the 24 hours. It's possible that is normal. So we need to take this into consideration. And if the clinical signs fit with an FCE, and we definitely rule out a non-acute non-compressive disc extrusion, or maybe what we can do is to do a follow-up MRI in 1 or 2 days, depending, or just make the assumption that we have an FCE that at that moment we don't see. Well, as I said before, it's very rare to find hemorrhage on FCEs, and if we give contrast, we are never going to see a contrast, a meningeal enhancement or epidural enhancement. Normally, we don't see any contrast enhancement, but if we do, it's going to affect normally the gray matter. So we have some examples of it. And the first one is a quite focal FCE. And now we look at the sagittal view only, we can see that this intramedullary lesion is just cranial, is above the vertebral body, is cranial to the disc space. So this is already different from the acute non-compressive disc extrusion. And on the transverse views, we can appreciate very nicely that there is no extradural lesion. Actually, the spinal cord is a bit swollen. The subarachnoid space is a bit thin. And we can see a very lateralized lesion, and it's mainly the gray matter that is affected. surrounded by a little bit of hyperintensity in the white matter. And on the T1 is iso-intense. We don't see any change. And this is an example of a very focal FCE. And on the next one, we see a quite different one, is way much more extensive. This one is extending over more than 3 vertebral body length. And on the transverse view, it's quite beautiful to see a really sharp demarcated intramedullary lesion. And you see that both the gray and white matter are affected, but the gray matter is way much more hyper-intense than the white matter. And we can differentiate them very nicely between them. We can see the butterfly of the gray matter. So this is as well very different from what we saw on the non-compressive text extrusion. And as I said before, if we give contrast, most of the cases we don't see any contrast enhancement, but when we do, and this is the next slide, we may see some intramedullary enhancement, and it's going to affect mainly the gray matter.
Someone is asleep, I'm afraid.
No, I'm fascinated taking it all in. I don't want to interrupt you.
If I wanted someone to look pretty, I would choose someone else.
That's flattering, Laurent. That's flattering. But I didn't want to interrupt, and especially didn't think you would interrupt as you swing your non-alcoholic beer again. Typical French. Okay, but thank you. Thank you for prompting me. Thank you for prompting me. Ines, thank you very much for that summary. Now, in this time of tremendous isolation, people are getting very lonely. And in Laurent's case, he now has approximately 16 cats that he's living with. And so one big question that he has is, how do the MRI findings in cats differ, if at all, to those in dogs?
So both in the FCE and acute non-compressive disc extrusion, the causes and the clinical signs and the imaging findings are pretty much the same as in dogs, but they are quite unusual. But there is one specific condition that happens in cats, that is the ischemic myelopathy due to hyaline degeneration. And there are 2 very nice papers explaining this. And it's very different in many aspects. First, the clinical signs are, I didn't say before, that in the FCE, the clinical signs are quite often lateralized, because the infras tend to affect more one side than being bilateral. And the dogs and cats with FCE, they don't have other clinical conditions. And the range age is from puppies to very old dogs. But in feline ischemic myelopathy, affects all cats, and most of them, at least in these studies, they all have a systemic condition. They have hypertension, chronic renal disease, hypertrophic cardiomyopathy, and there is a predisposition for the myelopathy to happen, or for this disease to happen at the level of C2. And this is because at this level, the vertebral, the spinal artery is narrower. And the cause of this is not an emboli, it's because there is a hyaline degeneration, an arteriopathy. And it happens in many arteries, but this one is especially predisposed because it's really thin. Another thing that is very different and is quite curious is that the clinical signs are, because the predisposition is in the cervical area, so normally they are paretic or tetraplegic, and they also have neck ventriflexion, which is normally not seen in FCE. And the clinical signs can occur again quite often. What we see on the MRI is normally quite, I think is the next slide, yes, thank you, are lesions at the level of C2. Again, it can happen anywhere else, but it's really common to see lesions at that level. And because at that level, the spinal artery is just a single one, and is irrigating both sides of the gray matter. It's very common as well to see bilateral unsymmetrical lesions, and because they are infarctations, again, they are very well defined, and they affect more gray matter than white matter. And in this case, we also have contrast, and we can see a very mild contrast enhancement that is affecting the gray matter, the ventral horns of the gray matter.
Great. You don't need to prompt me again, Laurent. I'm right on the ball right now. I'm right on the ball. I'm feeling pressure from you as well.
Well, we do it at your time. It's 2 o'clock in the US. So you're not asleep?
No, I'm not. I'm taking all this great information in, and I didn't want to interrupt Ines. Unlike you, classically, Ines is very rude on these things. I'm sorry, but so Laurent's very happy now to hear about cats. That's him satisfied. A lot of people though want to know: can MRI be used as some sort of prognostic indicator for these cases?
Yes, there is a study showing that in FCE, they measure the ratios between the intramedullary lesion with a vertebral length on the sagittal views, and when the ratio is more than 2 vertebral lengths, then the prognostic is quite poor. And also from the transverse views, when the intramedullary lesion is more than 67% of the cross-sectional area, the prognosis is quite good, bad. And also clinically, the absence of nociception is a bad prognosis. And on the acute non-compressive extrusion, is a bit different. The prognostic factor and the worst prognosis is when there is evidence of hemorrhage, intramedullary hemorrhage. And we see that when there are lesions that are hypointense already in T2, because if it's just Malaysia, it should be hyperintense in T1, in T2, as we saw before on the other examples. But if we see, like in this case, a huge area of hypointensity already in T2, even if we don't have a T2 star, this is an evidence of hemorrhage, and we confirm that with a gradient echo. So intramedullary hemorrhage is a bad prognosis.
Well, thank you very much for that. Laurent has obviously got somewhere to be. I'm hesitant to rush you, and to hand back over to him actually. But I am going to, and thank you very much, Ines, for this portion. And Laurent's got some questions, no doubt, from the general audience.
Thank you, Simon, for your amazing guest skill. I've got some great questions. The first one. In the brain, we use diffusion-weighted ADC to look for restricted diffusion to document ischemia. Can we do the same with spinal cord?
Yeah, there are some experimental studies using that, and definitely it's great. It's the way of confirming the restricted lesion and confirming an infarction. But it's very challenging to do that on the spine because there are a lot of artifacts because of the vertebrae. So it's already sometimes difficult to do that on the brain of a small dog or a cat, and in the spine it's not that easy to get a good image of diffusion. Yeah.
So it's more a technical issue, and in principle it would be great, but the technicality may be an issue. That's the main thing.
Yeah.
There's another question. How can I differentiate, I presume, either of the two from an intramedullary disc extrusion?
Because of the signal intensity. If it's a hydrated disc extrusion, it should be hyper intense in T2 and also hyper intense in gradient echo in the T2 star. If there is a hemorrhage, it should be maybe variable in the T2 star, but it's gonna be with signal void in T2 star in gradient echo. So it's when we differentiate that.
Okay. Let me see what else there is. I think it's more a matter of terminology. I may help you with that. Could you differentiate this disease type 3 with acute hydrated nucleus pulposus? I presume is non-compressive. What is the difference in stair sequence? I may help you with the type 3 unless you want to answer that, Ines.
Yes. Yeah.
You want me to say? Type 3 is a misnomer. When the type of degeneration, type 1 and type 2, were initially described, this referred to a type of degeneration that then lead to a disc herniation, namely extrusion for type 1 and protrusion for type 2. So the word type 3 should not be used because it was used in the past to describe this acute non-compressive disc extrusion. But you have to remember, as Ines explained at the beginning, there is no predisposing disc degeneration prior to that. So using the word type 3, in theory, we all know what it means, but it doesn't describe a type of degeneration that leads to an herniation. So it is actually the same thing. But regarding the stair sequence, I don't know if you wanted to comment or T2 star. I presume it's what you described already, no?
Yeah, the stair sequence, so it's a fat suppression sequence, and it's not going to help a lot assessing any intramedullary lesion because there is no fat on it, so there is nothing to suppress. It may help to assess the paravertebral muscles because sometimes we have some hyperintensities because of the trauma that is easier to see on the stair sequence. So I will use it to assess or to look better at the paravertebral muscles. Mm-hmm.
We're going to do a couple more questions before we close. In acute non-compressive disc extrusion, is the intervertebral disc material degenerated? Don't know if we can know for sure.
In general, what is described is that the disc material is hydrated, and this is what you explained now, and that's why we cannot call it type 3. So it's normally hydrated. Yeah.
One that probably would be important to clarify, and I may answer that for you. What do you think about surgery for this acute non-compressive? We want to stress that this is not a surgical disease. So the onset will be acute. Main differential will be fibrocartilaginous embolism. It will be compressive disc extrusion. But the cause of the neurological sign are the contusion. And even if there is a little bit of epidural material, this is, not enough to explain a neurological sign, and therefore surgery is not indicated, in any of these cases. So I think it's important, to stress. Let me see if we can find the last question for you. Does the location of the lesion in the spinal cord help you to differentiate between the two?
Yes, if the lesion is not centered in the intervertebral disc space, it can help us already because acute non-compressive disc extrusion is always centered at the intervertebral disc space. And also, regarding the region of the vertebral column, FCEs can happen in any area of the spinal cord. while non-acute acute non-compressive disc extrusions normally are in the thoracolumbar area. It's very rare to see that on the cervical region.
Thank you very much, Ines, for this great presentation. Before we finish, I just want to put on the screen, what we've got in plan for you for the next few weeks. Let me just put that. And in the meantime, I invite you just, to give a virtual applause to Ines for, this great presentation, today.
And thank you very much to everybody for being here.
But let me put that. So I apologize, I didn't have time to make a new slide. Obviously, Ines today talk about FC versus acute hydrated nucleus pulposus extrusion. Next week, we've got a very old friend of mine, Chris Falzon, that for those of you that like surgery, will discuss how does he manage disc-associated wobbler. In a couple of weeks, we've got Claire Rusbridge, which will do a session with us. How do I manage Chiari malformation and syringomalia, giving a lot of tips on, what is the basis of, the medical management and when do we consider surgery. That leaves me to thank you everyone for your continuous support with this session. I hope they are useful to you. Thank you to Simon, and thank you to Ines again for this great presentation. Have a good evening, everyone.
Thanks, Ines. Thank you. Thanks, everyone. Bye-bye.